So, what non-surgical options do you have if you want to avoid knee replacement? Well, a couple. The first one is, logically, medication. Now you might say, I tried medication, both standard pain medication like paracetamol, which is acetaminophen, as well as non-steroidal anti-inflammatory drugs, so-called NSAIDs, and they don't help anymore. But the problem is that many people use the wrong NSAIDs, which are not potent enough or have not enough penetration in the synovium, which is for example the case for ibuprofen, which has a poor penetration in the synovium, and that is exactly the location where you need it the most. The best NSAID to use is diclofenac 2 times 75 mg per day. That is the most potent for knee osteoarthritis. Somewhat less efficient alternatives are eterocoxib and celecoxib and naproxen. You should use an NSAID only during pain flare-ups, and maximum 7 to 10 days, and only when you have no risk factors, such as gastric or intestinal, renal, or cardiovascular antecedents or impairment, and only after prescription and approval by a medical doctor. The topical use of NSAIDs is actually also a good idea. They work better than you would expect, and this has been confirmed in several well-executed studies. So a pomade or a gel is really worthwhile to give it a try. You can combine NSAIDs with paracetamol, but paracetamol alone will usually not help, because it only addresses the mechanical part of the pain, not the inflammatory part, which is usually what you need as well. You should never use an NSAID above the maximum allowed dose, and never 2 NSAIDs combined, because that is really dangerous for serious side effects. And never for a long time, 1 or 2 weeks, so just during flare-ups. 2. Injection therapy. Injections obviously work longer. You have 3 options: hyaluronic acid, PRP, or stem cell therapy. Hyaluronic acid is the easiest and also the cheapest. It acts as a gel that is injected in the articular space and that impregnates the cartilage, thereby improving the lubricating and shock absorbing capacities of the joint. PRP, or platelet-rich plasma, is somewhat different. It is obtained from your own blood through a blood sample, out of which the platelets are extracted. When these are injected into the joint, they release local repair and growth factors, with the intention to restore and repair the cartilage layer. So these work somewhat different than hyaluronic acid. But for both PRP and hyaluronic acid, it makes little sense to inject them if the cartilage is completely gone. In other words, when there is bone on bone. So in these stages, when there is not yet bone on bone, both hyaluronic acid and PRP still make some sense. In the bone on bone stage, however, not anymore. Stem cells are a little different. These are obtained through fat tissue or bone marrow. So practically, it is definitely more cumbersome. But in theory, these could, even better than PRP, restore your cartilage layer. However, for the moment, and this video was recorded in August 2023, the jury is still out, and stem cell therapy for knee osteoarthritis is still somewhat experimental and also expensive. Let's say, if you want to try injection, stem cells are the last option if the other 2, hyaluronic acid or PRP, don't work anymore. 3. Brace therapy. There are 2 types of braces that you can consider: an unloader brace or a supportive elastic knee sleeve. An unloader brace does what it says. It unloads a certain part of the knee, either the medial or the lateral part, by pulling the bone surfaces a little bit apart, so that the bone-on-bone pressure is somewhat relieved and the pain is reduced. So of the 2 brace options, an unloader brace is the more fundamental one, since the pain is coming from the bone-on-bone contact. The downside is that the brace is often found uncomfortable, since it needs to be strapped relatively tight. Most people therefore use the brace mainly during a long time standing or walking, so a couple of hours per day, until they get bored of it and then they leave it out. And that is fine. The alternative is a soft elastic knee sleeve. That obviously is much more comfortable, but fundamentally it does not reduce the bone-on-bone loading. It just provides some symptomatic and functional comfort, and that's all. You also should not wear it all of the time, because it will make your knee indeed kind of lazy and dependent to it. It is therefore better that you build your muscles around the knee, which, if you achieve that, will have a similar effect as the sleeve. And that brings us to the next measures, number 4 and 5. And these you can do yourself. That is weight reduction and exercise therapy. And in fact, of all the options, these two are by far the most effective on the medium and long term. Weight reduction has a massive effect because the knee actually is a lever mechanism. So any reduction in body weight will create a 4-time reduction of the load on the knee. So 5 kilos less body weight means 20 kilo less load on the knee. And that is dramatic. And when doing stairs, up or down, it is even more. The factor then becomes 7. So 70 kilos less impact on the knee when you lose 10 kilogram body weight. Massive. And exercise therapy, of course. I have made a separate video on it. How you can strengthen your cartilage and your bone by simple, safe and comfortable exercise therapy. And what the fundamental key issues are when doing so. Please have a look at it. Thank you for watching.